From now on, we will have the third Small City International Symposium started. This symposium this time is hosted by the Ministry of Land, Infrastructure and Transport, Ministry of Science and ICT, and Incheon Metropolitan City, and organized by KAIA, Korea Agency for Infrastructure Technology Advancement, and IFEZ, Incheon Free Economic Zone Authority. Hello, my name is Sejin Yu, and I'm going to be your master of ceremony for the symposium today. This year's symposium will be a joint seminar between Korea and England, and thanks to the sponsorship from the British Embassy to South Korea. And I believe that it will be a great opportunity to share various knowledge and experience between two countries and strengthen mutual relationship. The symposium this time will have 4 sessions with different themes. The first session is about post-corona, where we can discuss mutual knowledge and experience in relation to the new concept of digital economy based upon various innovative technologies. The second session is for digital healthcare in line with the growing demand in new type of medical services, such as remote medical treatments under the pandemic situation like corona. Another important topic is smart city data, which is referred to as a core factor to create environment for efficient and robust urban management through data hub and data marketplace, which will be discussed further during Session 3. This channel will serve the Session 2, digital healthcare starting just right now, and the Session 4, smart mobility that will be started from 9 p.m. Korea and 11 a.m. UK time. Also, there are other sessions being held simultaneously. Session 1, post-corona, which will be followed by Session 3, smart city data. We are welcoming all of your interest and participation. Thank you. Before starting this digital healthcare session, I will introduce the session moderator, Professor Seok-Hwa Kim. He has graduated from Seoul National University College of Medicine and served as a director of the executive board, the Korean Society of Medical Informatics. He was the director of Seoul National University Children's Hospital and one of the leaders to promote the ubiquitous healthcare in Korea as the founding member of the Korean Youth Healthcare Association. Then, I will ask Professor Seok-Hwa Kim to proceed with this digital healthcare session from now. Thank you. From now on, we will have the third Small City International Symposium started. This symposium this time is hosted by the Ministry of...
Hello, I'm Seok-Hwa Kim, the moderator of the digital healthcare session. The third Smart City International Symposium will be held online due to COVID-19. This year's symposium board has selected the theme as resilience in smart cities with a strong desire to return to life before the COVID-19 outbreak. Therefore, in this session, we will have a broad discussion of how healthcare, which is an essential element in the city, should be done in smart city. This session is currently being aired on the YouTube channel, and we are receiving questions in real time. We look forward to hearing from you. I would like to inform you in advance that the presentations made by overseas speakers today are video recorded, taken by our staff in UK due to the corona pandemic. The Korean speakers' presentation will be held in real time at Gyeongwonje venue in Songdo, Korea. In addition, Korean and UK presenters and panelists are expected to participate online in real time. First, let me introduce you to today's speakers. We would be grateful if you could say hello on the screen. Currently, it is 3 p.m. in Korean time, but in United Kingdom it is 7 a.m. Thank you to the speakers and panelists despite the early hours. First of all, I'd like to introduce Theo Fortis, a principal lecturer at Brighton University as a British speaker. Next, I'd like to introduce CEO of Isansis HealthCare, Keith Airy. Next, I'd like to introduce Singin Lee, CEO of New Lake Alliance Management, is a Korean speaker. And finally, I'd like to introduce Kwang-hee Jang, Vice President of GE HealthCare Korea. At the end of this session, Professor In-young Choi of the Department of Medical Informatics at Catholic University of Korea will be in charge of the panel discussion on the subjects of the presentations. The presentation will take between 15 and 20 minutes. In the first step, let's watch the presentation by University of Brighton Professor Theo Fortis. Dr. Theo Fortis is also the academic lead for the Digital Health Living Lab, and his research lies at the intersection of co-production in healthcare and computing. Today, you will be given a presentation under the title of Digital Health Living Labs, Person-Driven Innovation.
Thank you and good morning. Good day. Hello, my name is Dr. Theo Fortis. I'm a principal lecturer at the School of Health Sciences at the University of Brighton, Assistant Director of the Center for Research for Secure, Intelligent and Usable Systems, and the academic lead of the Digital Health Living Lab in Brighton. I would like to first of all thank the committee for inviting me to this event. It is an honor to present our experience of the Living Lab. As you can see, the Digital Health Living Lab is a person-driven innovation. And the whole project was initiated by the observation that we would all agree that the healthcare problem is experiencing challenges. And one of the main challenges that the system experiences is that it's not sustainable for the future. Reasons are very well known as short-staffed systems, financial constraints, pandemics that we are experiencing at the moment, aging population which now presents to the hospitals with many comorbidities. So our main philosophy for developing the Digital Health Living Lab was that we should put humans before tech. And talking about living labs, let me spend a couple of minutes explaining what a living lab is. According to the European Network of Living Labs, a living lab is an open innovation ecosystem, a place where scientists like ourselves and other stakeholders can get together and can ideate, experiment, or evaluate any kind of solutions. So it is, as you can see in this circle, it is an area that it is a real-life environment where we, through co-production, we work with citizens and other stakeholders using multi-method approach, qualitative, quantitative methodologies, mixed method methodologies, engaging with these stakeholders and the users, having the citizen at the core of what we do, and with multi-stakeholder participation, we try, as I said earlier, to either ideate, develop, or evaluate new digital health solutions. As you can see in the photograph, this is where everything started. This is the LeadScore Digital Health Living Lab. It is the first one that we have developed. It is in the Brighton and Hove City Council, which is in the south coast of UK. And it is a place where around 150 apartments, single or double bedroom apartments are being established there. And it is a retirement accommodation. By retirement accommodation UK, we mean accommodation that people after taking their pension and retiring from work. They give some of their pension to the local government, which is managing the site in terms of heating and other bills, and then they live there independently. Talking about living independently doesn't mean that they are not under, healthcare or social care, but they live in an environment where it is free to get in or get out for them. And here you can see some of the stakeholders that we have initially engaged with, which it was the University of Brighton, which is the lead. We started the whole process and the whole development. The Kent, Sussex, Surrey and Sussex Academic Health Science Network, which is one of the networks in UK where they support innovation across UK and try to accelerate through their projects innovation. The Brighton and Hove Clinical Commissioner Group, which is the group which commissions any kind of solutions that are being implemented in the local governments. The Brighton and Hove City Council, and the Digital Brighton and Hove, which is an organization aiming to increase the digital literacy of the citizens. So what does a living lab provide? As you can see, it is an environment where we can innovate. It is limitless. We, through genuine stakeholders' participation, we're getting together, we communicate, and through collectively found decisions, we try to implement these decisions, and then with the support of the commissions, we try to see if they have really benefit, first of all, for the citizens, and second, for the local government and the financial sector. Stakeholders, as you can see, can be the service users, which is not only the citizens but also healthcare professional staff, local governments, and commissioners, as I said. In the living lab, based in the environment that I showed you and other environments that we have developed further, and led by academia, provides this environment where scientific expertise can come together. We have the advantage of dragging expertise from other academic areas, from other disciplines like computing, engineering, mathematics, social sciences, and we can do our research there, and we can evaluate the results of this research. And one of the most recent areas where we try to develop and benefit from the presence of living labs is education. Our aim is to use these real environments where citizens live their own lives as placements for healthcare staff that are doing their studies to go there and co-producing with the citizens, try to find innovative solutions to support their lives. Here I have a few photographs of some of the workshops that we did with the citizens at the Living Lab. As you can see, it is a nice, familiar environment for them. It is very, very collective. People are feeling free to express themselves. On the top left side, you can see a workshop that we did with an industrial partner where we were getting feedback on medium maturity product, and as the company was trying to develop it further. On the top right side, you can see some of the end users living in the Living Lab, which are the core users where we initially engaged, and below you can see some other workshops where citizens were providing their feedback on some of the workshops that we did with some industrial partners. So just being aware of the time, some of you might be thinking how we engage with citizens and how we start that. It was one of the challenges that I will talk about in a second. But briefly, what we do, we send invitations to people to participate in the launching event, as we call it, where they're coming there, and through tea and cake, we discuss what are the aims of setting up a Living Lab and how important it is to be able to collect their voices. How we do it. As you can see, the main inspiration we got from public intelligence user-driven health innovation methodology, which is a Danish company with experience on living labs. That was the main inspiration, and with their support we set up our main living lab. As you can see, These are the core elements of what we do. User-driven health innovation. We are trying to empower citizens, and it is interesting to refer to a project that we're currently running at the end. We try to link these social needs with health needs and innovation, and what we offer, and we are really proud to share that, is that we offer responsible and ethical innovation, because everything we do goes through, in our case, academic ethical scrutiny. So what are the main advantages then of a living lab, maybe based in a smart city? A living lab is a real environment, is what we call it a safe haven for the citizens. So the real environment offers a place where everybody comes, as I say, unbiased. And by unbiased means that we don't send invitations with specific agendas. People are coming there to share their dreams, visions, challenges, difficulties they're going through, and then we will work together after hearing their voices to try to find solutions. We do that through co-production. Co-production in any development, digital health development at the moment, is very, very important, and will be more important in the future. Having a product being developed from scratch with engagement with end users right from the beginning, it is a huge advantage for the output that we will have at the end, both for the citizens, the healthcare system, and the industrial developer, of course. Another big advantage of the living labs is that we can have what I call diverse cohorts. And by diverse cohorts, we can decide what kind of citizens we would like to engage with. Is it in terms of their age groups, in terms of their gender, disease-orientated, or it can also be groups that they are totally diverse, but we can bring in industrial partners that they would like to trial, evaluate their digital health solutions. Another very, very important element of an advantage of a living lab, which it was very importantly highlighted during the pandemic, it is that the living labs are environments which are self-sustained. And that means that they are there and they are present and they live even if we're not there, even if no project is happening, even if pandemic is hitting the society. And what I'm trying to say is that imagine that the Leach Court that I shared with you, it is a block of apartments. People go in and out, live their lives there, regardless our presence or not, regardless if we're running any projects. And that relates directly to the final point at the bottom, that there is no direct costs. Of course there are costs, but when I'm saying no direct costs, it means that we don't have to build new buildings, we don't have to set up new environments, we don't have to buy equipment. All the activities that you have seen in the previous photographs, they happen at the places where people are having their daily activities or they're having and enjoying their afternoon tea. This is where we go and we share this environment. But sharing our experience, what we try to do now is that through the funding projects that we are working in the Living Lab, we're trying to provide incentives for the citizens and give back something to the community in terms of covering expenses that they have to do with the buildings, for example, or the provision of Wi-Fi in these buildings. And I will be the last that I would complete this presentation by talking only for the good things, like pretending that no challenges are present. Actually, there were many, many challenges, but I'm proud to say that we have learned many lessons through these, and we have developed the experience and the expertise now to overcome these challenges right from the beginning, whenever we are being called to develop a new digital health living lab. As you can see, one of the main challenges that we experienced at the beginning was links with local government. Working in research and academia, it's not very common to have relationships with local councils rather than with the end users. And we have been lucky to be supported by the Academic Health Science Network and the University of Brighton through the relationships at the higher administration level with the local council, and develop these links and some governmental initiatives that they happened a few years ago. One of them was the Leading Places, where they brought together local governments and academia, and the Living Lab was one of these outcomes. Another challenge is the shared vision. It is interesting to know and to realize through the development of the Living Lab that what the citizens find as a challenge for their healthcare, it's not exactly what we believe as researchers that the challenge is, and what the commissioners or the local government thinks that they should prioritize for the citizens. And as such, through very good communication, through co-production workshops, through getting together very often, we managed to make the shared vision reality. Another challenge that I would like to share with you is identifying the right site. And the answer is, what is the right site? What do we mean by the right site? Everything is being led by the final aim of the project. In our case, for example, we wanted to help citizens that they are after their retirement, but before they have escalated care needs, before they need hospitalization. Of course, they might have comorbidities like or other kind of illnesses like diabetes or minor mental health issues. But in our case, we want to work with people that they could communicate their needs and try to find solutions that they will keep them there living in these environments before they need escalated care and hospitalization. So in another case, reflecting to a recent Living Lab, we were interested to see how we can trial, ideate, and evaluate mental health, digital health solutions. So we started working with university students. So depending on what we want to do, we have to decide for the right site, and this is where we can, again, support any kind of development. And the other challenge, as I say in the slide, as you can see, is identifying the right time. When is the right time? So the answer to this question is the soonest, the better. I mean, reflecting on the event about smart cities, if someone decides to set up and build up a smart city from scratch, this is where we need to engage with the end user, with the citizens, with groups of citizens that probably they will move in these environments and co-produce any kind of solutions that they will be implemented in this environment. Approaching to the end of the challenges, you might feel that trust is not very, very important, but actually it was extremely important. We realized that developing relationships of trust and relationships that people could share their visions, their dreams, their challenges is very, very important. It took time, but we managed to develop these trust relationships through continuous communication, contact, and always be present to listen to what people have to say to us. And last but not least, funding. I mentioned that no direct cost is needed for setting up a Living Lab, but if we want to run projects, if we want to evaluate solutions, if we want to implement solutions and explore the outputs of these solutions, funding is needed. And in cases like smart cities or local governments engaged in this kind of projects, mainly will be these local governments and councils will be the funders of these projects. In our case, we also work with applications on European funding bodies. And one of the projects that I would like to share with you is the Empower Care project, which is being funded from the Interreg 2Cs Mezen from the European Union, with along with other 12 partners. We are being funded to run a project where, working with our end users, the citizens in the Living Lab in our case, we want to trial solutions that would empower their citizens to take care of their own health, with the final aim, keep them healthier for a longer time living in their houses. And as I'm approaching the end, I would like to share with you some health visions. As my friend Peter Julius from Public Intelligence always says, any city can become a preventive city as long as we set up living labs right from the beginning. In these environments, in these living labs, we can cultivate this environment where we can take responsibility for each other in these communities because we know our neighbors, and with a vision to have citizens that they live outside of the hospitals, with no citizens living with chronic disease inside the hospital, and we can build a health system that it is always available and without waiting times and sustainable. So, and this completes my presentation. If you would like to hear more about living labs, how to set the living lab, the methodology behind setting a living lab, and discuss more about our experiences and our projects, please feel free to get in touch through my email that you can see in the slide. Thank you very much.
Thank you, Professor Theo, for this. The professor shared the development experience of Living Lab as an open innovation ecosystem and explained the challenges and benefits of using Living Lab as a tool for accelerating and adopting innovation within a smart city. Thanks for the great presentation. Next, let's watch the presentation by Isansis HealthCare CEO, Keith Airy. Keith Airy is the CEO and co-founder of Isansis HealthCare Limited. He is an entrepreneur and strong advocate of digital health and data-driven methods in healthcare. He has wide experiences in a number of technology industries, including semiconductors, high-power lasers, and medical devices. Let's watch the presentation by CEO Keith Airy on the subject of Internet of Living Things, patient-centric, intelligent digital infrastructure for non-localized delivery of safer, more resilient clinical care.
Good morning, good afternoon. My name is Keith Airy, and I'm the CEO and co-founder of Isansis HealthCare. And my presentation today I have titled An Internet of Living Things. But in fact, it really would be better titled An Internet of Medical Things, because the talk today is about patient-centric infrastructure for the delivery of safer and more resilient care within a smart city. So what do we mean by that? If we have a look at the first slide, the global megatrends that are influencing the future of healthcare are shown here. And these are reasonably well known, but let's look at them in the context of the smart city, today's topic. So first of all, we're looking at a new way of patient-centric care. This means that instead of the old idea of the doctor or the nurse or the care team being at the center of care, we're really making this patient-centric. And we see this in all sorts of consumerization trends in healthcare at the present time. There's also a real challenge around affordability of healthcare. And then really, to some extent, that lies outside of today's theme area, because we could talk for weeks on this. But this is an important trend to keep in mind. The other thing that is important, and this is right in today's topic, is that healthcare is becoming more and more connected, and it's becoming more precise and personalized. And so this is where we come to this idea of the Internet of Living Things, or the Internet of Medical Things. There's also a sense that there is a democratization of healthcare, a requirement that there is on-demand services for everybody. A long way off, but we're certainly seeing that trend in many countries at the present time. And last but not least, the huge elephant in the room today, the onset of global pandemics. What has this done to healthcare? And in fact, it's a very, very interesting time for any of us who are involved in the delivery of healthcare or the development of products, services that enable the delivery of healthcare. So all around the world, the healthcare systems are facing enormous challenges. Costs are going up, hospitals are getting more crowded. Interestingly, there's a global shortage of medical staff, particularly nursing staff. There's poor connectivity, poor interoperability between most of the systems that are currently in use, and that leads to many, many difficulties when we start to talk about digitization, connectivity. And the real barrier in many cases is that healthcare traditionally, and still is very largely siloed. It's siloed into different healthcare disciplines, different kinds of specialties. It's siloed into different places of delivery. It's siloed into different delivery organizations. And this is a real problem in many, many ways. And the last point here is that there is need for reforms in funding healthcare. And the funding of healthcare is one of the really important things. Again, it's kind of outside the topic area today, but always has to be kept in mind when we're talking about services, or in this case, technology for the delivery of healthcare. Before the onset of the COVID-19 pandemic, there were some clearly definable barriers to digital transformation in healthcare. So one of them was about the system diversity. Every hospital is slightly different. Every care provider does something in a slightly different way. Every country does things totally differently. And there is this diversity which makes a universal system or universal approach almost impossible. There are complex multi-stakeholder ecosystems that exist, and these also make it very, very difficult to be able to provide a kind of common infrastructure to be able to enable some of the services that would need to be delivered in the smart city of the future. Also, the clinical evidence base for many, many new technologies and new approaches, including things such as AI that we're hearing a lot about in healthcare, that clinical evidence base has still not yet been established beyond a reasonable level of doubt, let's say. So there's still a lot of work to be done there. There is a huge amount of work, or there was a huge amount of work around clinical process innovation. Many, many innovations in healthcare are technical, technological, or service innovations in a kind of commercial sense, but the actual process flows of delivering healthcare really haven't changed very much for, 200 years. So there is a huge amount of work that the healthcare provider community themselves realizes needs to be done here. And then, of course, there's the health economics. You can throw any amount of money into healthcare, and indeed we've seen this over the last 6 months, and what are the results? We could keep on spending and spending, but already the United States is already spending $2.5 trillion on healthcare, some 15% or more of the total GDP. Other countries have very, very high levels of spending and want to increase that, but that's not sustainable. So the health economic evidence base for any new innovation also needs to be established, particularly as we're talking about how this can be delivered in these new smart city environments. And then finally, regulatory. The regulatory landscape, as everybody knows in healthcare, is very tough. It takes a long, long time to develop and then test, prove, and get onto the market any kind of pharmaceutical product. It also takes nearly as long these days for any kind of new medical device. So there's an inherent delay there. So all of that was the situation around the beginning of this year. But as we all know, we've been hit by the COVID-19 pandemic. Every country has suffered. Every country has dealt with it in a different way, some extremely well, some very poorly. But what has happened is that a number of things have started to change, and change very rapidly. So let's have a look at healthcare system diversity. Wow, all of a sudden, there were many, many different new kind of business models that appeared and were explored and were implemented. in 6 months. The multi-stakeholder ecosystems had held up so much progress. All of a sudden, different providers, different care groups were getting together to provide care for citizens who really, really needed it. The clinical evidence base? Yes, absolutely. Safety became a key requirement for anything that new that was being delivered. But efficacy? Efficacy can take years to demonstrate, to prove. In this case, we saw, particularly with the FDA in the United States, the fact that you could get products out quickly and in a very rapid way onto the market. Efficacy was to be shown as the product was being used, not before. Big step, big change. And then process workflow innovation. I heard only this week the medical director of the Oxford University Hospitals make the following statement. In the last 6 months, we have been forced to re-engineer healthcare in ways that haven't been able, or we haven't been able to do for the last 20 years. 6 months, because of the COVID pandemic. And the health economics business case seems to have been thrown out the window. Look at the money that's been thrown everywhere just to try to stop people dying, to be able to deal with what's been happening. Suddenly it doesn't seem to be necessary, but actually it does, truly, and again, the process here is to get the treatments out there, get the products out there, try the new services, test the economic viability from real-world evidence. A big change. And then the regulatory landscape. Yeah, we've already said, the FDA, for instance, emergency use authorizations became a standard thing that we heard about. Many, many new devices, many old devices were suddenly repurposed through this route. And again, efficacy is to be shown through the use or, the lack of efficacy once the product is out there. Provided it's safe, what's wrong with that? So all of a sudden, in all these areas, we've seen huge changes because of the pandemic. So what does this now mean? What does this now mean for providers, for suppliers? And coming back to the topic of this conference, what does this now look like? Well, we know, and on the slide makes this point, telehealth has surged. Various numbers can be found, but prior to the COVID crisis, telehealth was being used routinely by around 10 or 11% of US healthcare organizations, delivery organizations. Suddenly, that surged, probably 40 to 50% now using it, and over 75% saying they will use it. So, huge change, huge change. But let's keep in mind most of the telehealth services, and most of these things are reasonably well understood, really have been addressing what we would call primary care. Primary care in the community, care particularly for people with chronic conditions rather than acute conditions, but being able to have that delivered without those people having to go to the doctor. In fact, the doctor virtually comes to the people, or comes to all of us, through various kinds of virtualized means. And within that, it's also possible not only to have teleconsultations, video conferences, even things like a Zoom call with your doctor, but also because there is now a new class of devices, wearable tech, we see them from the big companies. This gives a reasonable amount of data on which a remote diagnosis or even a triage can be achieved. So big change there, but mainly, as I say, focused on primary care. Now, what does that mean when we start looking at what happens next? We're really interested, or this talk is really interested in the delivery of secondary care. So what do we mean by that? How do we deliver secondary care and tertiary care in the smart city. Currently, it's delivered in hospitals. Now, hospitals, what are they? They're centralized facilities. They're actually very inefficient. We know that now. But it means that all or most of the facilities that patients require are in one place. Seems like a good idea, but in fact, the costs of doing that are going up. And not only the costs, what we've now seen within the COVID pandemic, people don't want to go to hospitals. Hospitals have become quite dangerous places. We have various figures, but it looks like hospitals are one of the epicenters of infection for this disease. So what is the point of the hospital? In many big cities in the future, particularly in places like India, where there is poor infrastructure in terms of transport, it takes too long to get to a hospital. So something needs to be done. And if we're looking at the smart city, how do we do this? How do we deliver higher acuity tertiary and secondary care in a smart city? Let's have a look. One of the ways of looking at this is, in fact, if some people don't quite understand what I'm talking about when I say primary care, secondary care, and so on, there is a well understood structure which is a triangle of care. So at the top of the triangle, and you'll see this in the slide, we have tertiary care. This represents the kind of care that is delivered in an intensive care ward typically. Under that, we have intermediate ward care, which is secondary care, the kind of care that you get if you just have to go into the hospital and have routine kind of operation, or you're recovering from an incident that meant you were in tertiary care. Next one is primary care, and primary care is care that's delivered through the local doctor or delivered in a clinic, and we're all familiar with this. This is what we access most of the time as citizens. But now we have something new starting to emerge, and this at the base of the triangle is far and away the largest grouping and starting to get larger, and that is what we might call consumer healthcare. Now, consumer healthcare is really interesting because it always happens in the home or in the place of work or wherever we are. And let's have a look at what that means then in terms of data that can be collected in these places and what the function and use of that data is going to be. So the next slide shows that if we look at the triangle of care, the data quality shown on the right-hand side, data quality has to increase as you go up towards the top of the triangle. If you're being treated in an intensive care ward, you're not being treated on the basis of the data from your Apple Watch or your Fitbit, or even, dare I say it in Korea, your Samsung device. For the patients who need this kind of care, absolute accuracy, continuous monitoring at all times is necessary. However, if we look on the other side of that, if we look at what happens when we come down the triangle into that very large area of consumer care, what are we seeing? We're seeing more and more people who are using the kind of devices shown there, various kinds of consumer wearables. And what's happening there is that we're starting to see some really interesting population data from these devices at the level of an individual who understands that it's quite messy data, but nonetheless can help them. It's very useful. And it also can show trends to the individual and the physicians. And it can also be used for that reason for screening. It doesn't have to be 100% accurate, but it can be something that says, hey, you might have a little problem, come along and let's have a look at this. So in order to get that data, we see on the right-hand side of the screen the kinds of devices that are necessary. If you're in an intensive care ward, you're cabled up. You have big machines by the bed. You need to have those things because that is the way things are done right now. And that is the way the doctors can have that real-time, trusted, usable data. And secondary care, you might have some sort of machine monitor by the bed. Doesn't have to be as big or as cumbersome as those in an intensive care unit, or a nurse is coming around and taking your vital signs, your OBS, on a regular basis. As we move into primary care, we see there's a whole range of devices, and in fact people are starting to buy these for use at home, and the primary care community is actually starting to interact much more across that primary care boundary into consumer healthcare than previously. So these are the kinds of devices, these are the kind of functionalities, and this is what the data is being used for in that case. So having understood how the primary, secondary, tertiary, consumer care is arranged, let's have a look at what would be needed if we wanted to deliver that, or the future of secondary care, possibly even tertiary, but the future of secondary care in the smart city. How could we do that? Well, we really need to virtualize the hospital. Now, is that possible? Yes. Is it likely to happen? It is happening. It has to happen because, as we've seen, the hospital is not a good place to be for many patients who previously would go there. So how do we virtualize the hospital? A very big task, and many aspects of that. Only one of which that I'll deal with today, because this is the basic underlying technology that could be used to virtualize the hospital. So if we have a look at the slide, I'm suggesting this is what we should do. So you take the very large, cumbersome intensive care devices, and you take the bedside monitors that are used in secondary care, and you combine them with the ease and the usability and connectivity of wearable tech, the watches, the wristbands, the other bits and pieces that are out there, and you create a whole new system for being able to collect data from individuals in such a way that secondary care can be enabled. Now, what would be the requirements for a system like this? What would it actually look like? So the next slide then looks at the requirements for this kind of system. What would be, how would we put together this Internet of Medical Things if we wanted to deliver secondary care or even tertiary care outside the hospital, somewhere in the community outside the hospital? The first thing, it has to be a system, a platform or infrastructure which is trustworthy and absolutely secure. And that trustworthiness comes about, means various things here. The data has to be actionable, and actionable by a clinical team. And it cannot need to be second guessed in some way, and it must be available at all times. The system, any system like this, cannot be siloed. It cannot be siloed by one supplier, one manufacturer, one hospital group. It has to be open, and it has to be, and it has to enable or has to have the ability to introduce other devices and other systems, or it must be able to be interoperable with other systems. It also has to collect all the necessary information, all the necessary data. It can't just take one signal from the body. It can't just take one video channel. It can't just take one reading from some other kind of instrument. It can't just take only what the patient is reporting. It has to be able to do all of those, and it has to be able to do those all simultaneously when necessary. And it has to be always on, and it has to be bidirectional. So already we're starting to say, yeah, there's things like this around, but the important thing, as we already mentioned, is that it has to be clinically actionable. And it has to be actionable both in terms of the data it's collecting, but really, really importantly, any alerts from that system have to be absolutely rock solid. Very low false positives, very low false negatives. We'll never eliminate them, but they have to be so small as to be not an impediment to the use of a system like this. It has to be predictive. It has to be predictive. It has to be able to say what is going to happen to that patient from that information which it's collecting at some point in the future. And that is the real key. Because if that can be really implemented, then all care can be switched from being almost totally reactive to proactive, which means that in this idea of the smart city, the care team has warning, has time, has the ability to be able to organize the appropriate level of intervention or care for that particular patient at a particular time. If that window of prediction is hours, that's probably enough to start with. If it's days, then that's even more interesting. But if it's hours, the care team can move across or come to the patient. Why do we take a patient to the hospital in an ambulance? An ambulance takes up a huge amount of road space. It takes a large amount of energy. It's a cumbersome kind of machine. But if all of the information, if all of the services that that patient needs aren't necessarily at the hospital, why isn't the doctor or the nurse going to the patient? They can do that on a motorbike. A much smarter solution. Or in fact, they could do it on the electric scooter. A much easier way to organize things in the future. So the other thing about this then, if this is to be the case, this system really has to be what would be effectively a medical device. This is why the medical device regulations are in place, because the doctors, care teams, nurses, clinicians need to trust the information, and that has to be assessed through the medical device regulatory process. So that's the requirements. A lot of things all in one, but what I'd like to say, and one of the reasons I was asked to be involved in this conference, is that at iSansus we have created such a platform. It's early days, but it does all of the things that I've just described. And it's starting to be implemented in various kinds of early stage projects whose intention is not just to investigate, but the intention is to move the kinds of preliminary projects, investigatory programs from that into what is called standard care. And the interesting thing about this platform, it's equally at home in a hospital. In fact, we began in the hospitals. We recognized that we had to engage the clinical teams, the clinicians, the nurses, in the system before it could be used by them in a way that they would trust in the community. And the system we call the patient status engine. And the patient status engine is now something that we are involved in such a way that we see that we have created this infrastructure. And the infrastructure is open. Many of the clinical teams we're working with are developing their own predictive apps that run within this platform. So we don't own the apps. We might work with them to commercialize them, but equally they can be used in other platforms, other systems. And so what we're looking at here is a really interesting future, an interesting future where we can virtualize the hospital, we can use data in totally new ways, we can use that data to highly personalized treatments, we can move care away from those points where, these agglomerations called hospitals, into the community, into people's homes or wherever they want this care. And what we are seeing is that I have been doing this now for the best part of 20 years. We're seeing something happening now which is going to be able to be driven in the next 3 to 5 years, not the next 25 to 30 years, but the next 3 to 5 years. And these systems these virtual hospitals, virtual wards will come into existence, and the benefits for patients, for all of us, for providers, for payers, are going to be enormous. So I'd like to finish there. Thank you.
From now on,
Thank you, CEO Keith Airy. He will explain the requirements and examples of technology that can provide high-level treatment, such as the virtual hospital in the smart city. I appreciate his great presentation with enthusiasm as the global leader. Third, we will invite the New Lake Alliance Management CEO, Singin Lee, to the stage. Singin Lee has been the CIO and partner of New Lake Alliance since 2013. Let's watch CEO Singin Lee's presentation on the subject of a case of COVID-19 response and digital disease management system in Korea. Please.
Thank you very much, Professor Kim, for a kind introduction. Before I begin, first of all, I would like to thank Kaya, President Son, and other government agencies for giving me this opportunity to speak today. Also, it is a great honor to share this podium with so many experts from Korea and UK. Lastly, we're hopeful that this symposium will be a stepping stone for further collaboration between us two countries in both in public and private levels. Although we are physically apart, we can never overemphasize the importance of knowledge sharing to fight against this COVID-19 problem that we face today. In terms of my presentation, we will briefly discuss who New Lake Alliance Management is and our role in terms of healthcare investment side, as well as give you a presentation, a snapshot of what we have created as Invites ecosystem, and then briefly walk through our own COVID-19 experience and lessons we learned via one of our portfolio companies, and then introduce City Health Monitoring System, CHMC for short, and how this system can be implemented in smart cities in Korea and hopefully in global level. New Lake Alliance Management is a Korea-based private equity fund manager established in 2013. Since its inception, New Lake Alliance invested over $300 million to sponsor 13 small and mid-sized Korean healthcare providers with clear leadership in their respective specialties. New Lake Alliance is a firm believer in the concept of ecosystem to encourage open innovation, especially in the healthcare space. As you can see, we have covered a wide spectrum of healthcare businesses over the past 7 years. On the far left, we really started with offline healthcare providers, and one of the clear cases was in 2013. We invested in Cha Healthcare, an operator of Hollywood Presbyterian Medical Center with 430 beds, which makes it one of the largest general hospitals in LA. Cha Healthcare also operates Tokyo Stem Cell Center and high-end healthcare checkup center. Also in 2017, one of our portfolio companies, Sun Healthcare, acquired Huntington Beach Hospital in California, which is an ambulatory surgery center to treat and offer treatments for orthopedic problems for athletes and elderly patients. In the middle is the investment in digital healthcare and smart hospital. Having invested in these offline hospital business in the US, we realize how the digital transformation is taking place rapidly across the global markets. We saw that future of our digital healthcare providers will improve and widen the access of quality healthcare service for people who otherwise will not have access to it. We also like the fact that this sector is projected to grow from 140 billion US dollar market and reach 600 billion by year 2025. Therefore, in 2018, we invested in a digital healthcare company called HealthConnect. This is a joint venture between SKT, the largest mobile telecom operator in Korea, and Seoul National University Hospital. In a separate transaction, we also established Invites Healthcare with SKT, and subsequently we acquired Biocore, the largest local CRO company, and also TransGlobal, a healthcare logistics company, to create what we call Invites Ecosystem. At this point in time, we believe that due to COVID-19 crisis, we're very optimistic that the strong interest and also urgent need for non-contact healthcare services, and that will lead to lower Korea's regulatory hurdles in the near future. And also, if you look at on the right side, we have made investments also in pharmaceuticals and biotech companies. This slide shows what we just described as an Invites ecosystem. It is mainly made up of 4 companies: Biocore, HealthConnect, Invites Healthcare, and TransGlobal Healthcare. We are in the process of fully integrating these 4 businesses, and once completed, we expect significant synergistic outcome. As a single ecosystem, if you will, we have 139 medical and R&D professionals, 146 healthcare-related intellectual properties. Cumulatively, you have 37 years of healthcare experiences. And on the right side is more financial numbers, but yeah, our total asset size is $145 million US. As a whole, we expect to generate about $53 million in terms of revenue, and we expect to triple that in 3 years. It will also generate positive EBITDA of $5.2 million end of this year, and this is going to be quadrupled by 2024. Unlike other startups and peers, Invites ecosystem generates positive cash flow, which will support our R&D efforts to develop more innovative services and products without relying too much on external funding. Another important feature of our ecosystem is we have about 6,725 distribution network. Because of our existing sales infrastructure, our innovative product and service can be quickly hit the market as soon as they are ready. We believe Invites ecosystem will be a great agile healthcare partner for Korea and also Asia and region. Now we would like to share HealthConnect's own small but successful COVID-19 experience. Just as a reminder, HealthConnect is a joint venture between SKT, Seoul National University Hospital, and New Lake. It has a market leadership in providing smart healthcare solutions to hospitals and businesses, and we've done that since 2011. Just for everyone's reference, since February 10th of this year until October 5th, Korea overall had 24,000 plus cases of COVID cases and 430 deaths or so. Having said that, in the first quarter, North Gyeongsang province was hit hard by COVID-19, and the sudden surge of patients overwhelmed the local health and hospital system. To deal with this crisis, Health Connect quickly developed and installed first-generation city health monitoring system, and then was operated by Seoul National University Hospital personnel. CHMC 1.0, that's what we call, provided X-ray image sharing platform, remote vital sign measuring capabilities, mobile medical examination system, and home care monitoring app. We treated over 100 cases, and without any further complications, it proved to be very effective. Having gone through this firsthand, Health Connect learned a few lessons. First, socially vulnerable and people with preconditions suffer the most in this crisis. Secondly, we need to be very proactively preventive and therefore establish a response countermeasure system in place before the next outbreak. And three, this will be the new norm going forward. Well, from the lessons we learned, Health Connect is preparing to launch CHMC 2.0 in the near future. Health Connect is actively working with public health officials to roll out this system for public health purposes. Notably, we are currently collaborating with a large, major ICT service provider which will install smart city systems in major cities in Korea. Recently, this consortium was selected as the contractor for two major projects. To serve its smart city purposes, the key difference between CHMC 1.0 versus CHMC 2.0 is its duality. CHMC 2.0 is dually configured to serve and improve health of people suffering from chronic conditions in normal times, and also proactively respond in the event of epidemic crisis. In normal operations, the system will continuously accumulate gene and medical checkup data from hospitals and medical checkup centers, and then also live log data from wearable devices. So this will eventually turn into CDS system so that we can assist physicians and other health professionals with clinical support decisions. But in terms of event of epidemic outbreak, the system will convert into screening potential risk groups so that the CHMC can take proactive measures. And once detected, we will take those patients, isolate them, quarantine, and provide remote treatments, and then ultimately discharge. This next slide shows more of end users' perspective in terms of how this system works. In normal operations, there will be medical checkup, and just for the reference, Koreans are required to take health checkups every 2 years, and it's covered up by the insurance. So with the checkup, that will get all the data that will be inputted into CHMC system. And with the proper analysis, there will be prescribed of diets and exercises that will be suitable for that patient. And then with that data, we'll also be going into CHMC system. And the staff at the CHMC will analyze and make sure that those patients follow those rules. But in the event of epidemic outbreak, they'll be systematically screening and take proactive measures to make sure that the isolation happens and the treatment is well followed through. This is control tower, or what we call AI platform for CHMC system. It will be well coordinated between the Center for Disease so that we can actually identify and make sure that all the information can be followed and stored. The information will be shared with the hospitals so that the local community can be served. And then in terms of citizens, we will be able to communicate and take all the vital signals so that patients' conditions are followed. And then if the tests are required, and then the test results will be sent to clinical laboratories, and in emergency cases, it will even dispatch emergency cars. Basically summarize some of the technologies that's currently held by Health Connect. It's really focused on three things. First, chronic disease management solutions, remote medical care solutions, and then disease prediction using AI algorithm. So there are a lot of technologies that our ecosystem possess. However, we always believe in innovative sharing so that we are very open to not just developing our own technology, but also benchmark and using other global players and partners so that we can better serve our customers. That's the end of our presentation, and hopefully through this symposium, once again, we can find ways to collaborate with our partners, and so I look forward to having more discussions with you. Thank you.
Thank you, CEO Seung-In Lee. He shared the development experiences, non-face-to-face medical services, such as a city health monitoring center during the COVID-19, and his experience of expanding to the chronic disease management. Thanks for the great presentation. Lastly, I'd like to invite Kwang Hee-jang, Vice President of GE HealthCare Korea, to the stage. Kwang Hee-jang has been at GE HealthCare for 20 years, seeking the application of cutting-edge medical technology and development strategies of the Korean medical market, and has contributed to various countries in Southeast Asia to receive advanced medical services through advanced image diagnosis equipment. Let's watch the presentation on the subject of adoption of digital technology for future hospital by a Vice President Kwang Hee-jang. Please.
Thank you for a really nice introduction, Prof. Kim. My name is Kwang Hee. I'm working for the GE HealthCare Korea. Today, my topic is one of the adoption of one of the digital technologies for hospital operations. I'd like to share our experience. Then I think we can have a really good session to learn each other. Firstly, before I go to my presentation, really, really thank you for inviting me for this opportunities and the venue. It's pity that some other people cannot see the ceiling of this room. It's really Korean traditional hotel, and ceiling is really nice. So I think next time, if we can have another sessions, I like to have a really offline session here. Before I move to my presentations, I'd like to introduce about our company. G HealthCare is under G General Electric Corporate. We, as known as a provider of diagnostic imaging like MR and CT, it's a big product for radiology or nuclear medicine departments. But also we have clinical solutions. It's like monitors of patients, EKG or ventilators, anesthesia machines. And if you go to the right side, then you can see we also have the small pharma business and biomarkers. And in the middle, we have IT solution for healthcare. So G HealthCare is, if you know that about healthcare industry, we are the very few companies can have the solution of the product and pharma and IT for healthcare. So it helps us to think different way about healthcare and future of the hospital. We have the visions of precision health. I'd like to introduce what's our visions. If you're very familiar with the healthcare, like 10 to 20 years ago, we mentioned about what we said about personalized healthcare, personalized treatment for certain disease. So we believe that if we can find the characteristic of a certain disease, then we can find the right treatments for that personals. That kind of concept changed to precision medicine. So you can see there the precision medicine, but it's more like clinical purpose. Of course, it's very important because, in healthcare, the mission in the healthcare, we want to save the people's life. Yes, that's true. But in the change of the current situation and societies, they all mentioned, in the previous presentation, they all mentioned about aging populations. And the burden of the healthcare is really big. You heard about how much the U.S. government spent for the COVID-19s. But before the COVID-19s, healthcare expenditures in U.S. is about 20% of their GDP. If you move to Japan, it's about 14%. We have people from UK. UK is a little bit lower, but it's 10%. Korea, we are trying to maintain below 8%. But because of population change and other problems, the healthcare expenditure will go up a lot. So our question is, how we can help our clients and people to have sustain the healthcare structures, that has a precision care and operational view. Then I think in the futures, in order to maintain the quality of cares and maintain our healthcare systems, then we have to go to two ways. One is the precision medicine, and second is precision care. Before I move to share our experience, I want to show you one of the pictures. I think people from UK is very familiar to them. This picture is the Winston Churchill's command center in World War II. Then I want to show you next pictures. It's a little bit modern. So I think young generation will not think it's modern, but it's in 1970s pictures. It's NASA's Mission Control Center for Apollo 11 when it touched down, when it arrived in the moon. So all the important and complex missions, there's somewhere have real-time communication and decision makings and real-time monitoring of the missions. let's move to real topics. As I mentioned about the prison health, as a company, we had a broad view in the healthcare from equipments, ITs, and some monitoring solutions and pharma business. We don't think that, okay, how we can help our client to sustain the healthcare systems. So we started a project for about 15 years ago. Its name is the Hospital of Future. In the short term is HOF, HOF. So we see there is change of the economy, there is change of the populations, there is change of the people, the behaviors, and change of the technologies. How we can make future hospital concepts. When we start this workout, everyone came up with some crazy ideas like a science SF movies, science fiction movies, and a lot of technologies. But we don't want to be like cloud, we want to be more practical way. So we decide, okay, let's go back and let's see what kind of problem our client have. Then can we find some solution to help them? So this is one of the example of the problems of our major clients has. It's 1,000 bed hospitals. 1,000 bed hospital is pretty big. In Korea we have many hospitals, but in the worldwide it's not that many hospitals has 1,000 beds. And their problem is, if I start from the number one, there's a long queue for emergency departments. People cannot go in. And it's very difficult to find a slot in the operation room for really, really acute patients. They need surgery right now, but it's difficult to find an operation room for them. And there's holding for a while, there's holding for the ward and ICU. So they have problems of the patient capacities. But again, 1,000 bed hospitals as a really good quality of cares. And we still believe that everyone, if you are sick, you should go to the good hospitals. So there's big demands, but supply is limited. And if you are from other industry, then you can simply think that way. You can build a building and make more supply. But it's not easy in the healthcare. As Keith mentioned, we have a problem with the medical staff. Training medical staff, have a good medical staff, it takes 10 to 15 years. So, we cannot simply just increase our supply. So what we think is, okay, can we find a way to improve the utilization of the hospital systems? Then they can do better. So we started to look for some other industries, so we benchmarked. So we go to NASA, we go to airlines, we go to nuclear plants, where there is really important missions and complex missions. And the people there is professional. Professional has different mindset from normal people, by the way. So we found that those organizations has real-time monitoring solution for overall their systems. And they communicate there. They make a decision for preventions. So we thought that, okay, what about hospital? Can you do that? So we made the concepts. So we have a command center in main hospital or hub hospitals that you control hospitals, but at the same time you can control other hospitals or remote place. Then maybe you can cover smart cities or other states. Other areas. So right side, that's our first command center in Johns Hopkins. We started installation in 2017. Then that's the real pictures. So all the important informations we can show them, and there's prediction models, and then we really focus on action to solve. Then when we built this hospital, these command centers, we have to choose what's the right technologies to help them. Can we help them to predict patient capacities every day or every minute? So when you look for those technologies, we found the digital twins. So digital twin technologies is like computer simulations, big data analysis, and AI all together. Then you can predict how the system responds and what are the problems. So it starts from aviation engines. Then we use this concept for the hospitals. So I had the movie for that, but this online presentation I cannot show the movie. But you can see we use a different algorithm to show the hospitals, like real digital twins with the layouts, patient flows. So we use like 1 to 2 years hospital informations going into the hospital, going out. In the middle, there is a lot of information. Then we create one of the digital twin for the hospital. Then we use these simulation models every minute. Then we can see what kind of problem will happen in the middle in the patient flow. So this is the result of Johns Hopkins. So we reduced the emergency department waiting time about 30%. And important thing is that they can get more transfer, 20% acceptance. That's really good for the critical patients. So we had Frost and Sullivan Award in 2018. And so far in the worldwide, we have about 20 command center installed. In UK, we have Bradford under NHS. We installed last year. But after COVID-19, there's other change too. Because if you see from the top, that's all the hospital names in it. But in the middle, a little bit below, you can see Saudi Ministry of Health and Dubai Ministry of Authority. They choose to have the command center concept to have more strategic decisions. And in the middle, at the bottom, we have Oregon State. So for the COVID-19, we connected about 55 hospitals, and we are managing the resource like negative pressure beds, ventilators, and some resource they need the COVID-19, so we can help them to utilize better for COVID-19 patients. This is one of the examples we use the digital technology for the future hospitals, but I think we have a lot of scalable opportunities. It's like a Lego blocks. So we're thinking to combine a virtual care into command centers. We are thinking to combine AI more like a clinical purpose. Then I think it can help the overall systems together. This is interesting pictures I really like to share. This is the 2005 when new Pope inaugurated, so inauguration of the new Pope. If you see bottom, right side bottom, there's one guy taking pictures of the Pope. That's 2005. When 2013, when we have a new Pope announced, you can see everyone take pictures. So I think adopting digital technologies, even in the healthcare, that's a trend. So I really like to see, the future in the healthcare with the digital technologies. Thank you. This is my presentations. If you have any questions, you can send an email to me too. Thank you.
Thank you, Vice President Kwang Hee-jang. He explained the experience of the clinical command center. This is a hospital medical system using AI technology. And well, explained the quality of medical services should be improved through the efficient use of digital technology. Yes, we have heard all the presentations prepared so far. It seems to have been an opportunity to better understand what technologies can be applied for digital healthcare of smart cities in UK and Korea. From now on, we will take a moment to consider the panel discussion and strategies and countermeasures to respond to post-corona era in the future. In addition, we will ask selected questions to the speakers among the questions given in real time and those previously received through the website. I'm afraid we are a little bit behind the schedule, so we are going to rush in. Yes, first of all, let's hear the general opinion of Professor In-Young Choi as part of the panel. Since 2015, she has been the Associate Professor of the Department of Medical Informatics, Catholic University of Korea, and is also the Director of Intelligence Medical Data Center, Seoul St. Mary's Hospital. She was nominated as the Deputy Head of the Information Strategies Department at the Catholic Central Medical Center in 2020. We are all really looking forward to listening to your opinions on today's announcements. Please.
Yeah, thank you for your nice introduction. I'm In-Young Choi from the Catholic University of Korea. Before we start the discussion, I appreciate the organizing committee to open the digital healthcare session and invite me to have a panel discussion. Also thank for speakers to share your experience and insight for smart health and smart city. In my opinion, medical field and smart cities is a very closely related topic when it comes to the importance for citizens to maintain a healthy life. Recently, many cities are overcoming COVID-19, so I believe this full presentation provides us how to overcome and respond to this pandemic situation. We have a first speaker, Dr. Theo Fortis. Thank you for sharing your experience in developing Living Lab as an open innovation ecosystem and its application, challenges, and benefits. I think the Living Lab model is a very prospective healthcare innovation model because all stakeholders can come together to share ideas and find improvements. In particular, if users and industry can participate, express various opinions, and seek making changes, I think it will be a good model to prevent disease and create new services. However, as Dr. Theo suggested, that gathering different opinions from diverse stakeholders can be a long process, and the cost of compromising different opinions will be very high. So we should consider how to maintain that financial support from the government and industries. Also, we have a second the presenter, Mr. Keith Airy. Thank you for your great presentation. I agree that the hospitals after COVID-19 will quickly transform into a new model where data will be generated from different devices from primary, secondary, tertiary hospital, and even home care, and data will be integrated on a central platform. Also, as you mentioned, the virtual hospital, but maybe many doctors don't like that terminology, but I completely agree with you, the hospital will be transformed into some virtual thing. And the platform will help the providers and patients to manage diseases, and artificial intelligence provides the prediction how to progress the disease. So I completely agree with you. In future hospital, the central platform will be very important, and the data compatibility also very important. Otherwise, the platform can limit healthcare services. And we have a third speaker, Mr. Singin Lee from the New Lake Alliance. Thank you for your great findings and presentation. As you know well, the COVID-19 has greatly changed the medical service process in Korea. Through the CHMC, City Health Monitoring Center, the Health Connect developed an untapped medical service center system. I'm very proud of it. It's a successful testing and great quality of care in Daegu. As shown in the presentation, if this system were established before the outbreak, I think we could respond better than before. Now the coronavirus is spreading not only in Daegu, but across the country. So therefore, if other cities can apply and share Daegu's experience, we can manage the spread of infectious disease more efficiently. Furthermore, you said that you have a plan to improve this system, and this system can respond to general situations and emergencies to provide service to domestic and foreign smart city project. So I'm looking forward to its future direction. And lastly, we have last speaker, Mr. Kwang-hee Jang. First of all, I would like to thank you for making a good presentation on the subject of applying digital technology for smart hospitals. Personally, I'm very interested in clinical command center. It is exciting to imagine we can control several hospitals simultaneously sitting in the command center. It is like Star Trek. You said it's being applied to some hospitals in other countries, but it is very bad that it has not been applied in Korea yet. I think it is because our medical law does not allow to integrate all of the data from different hospitals. Therefore, it would be great to apply this system to Korea as well. And looking at the presentation, it appears to an integrated system can collect all information and respond and centralize the center. So I think we need some balance of what should be managed by the sanctuary and what should be managed by locally. Thank you for all speakers. Thank you.
Yes, thank you. Now, shall we exchange questions between the presenters? First, I would like to ask Professor Theo Fortis, please.
Yes.
Could you start the
please.
questions among the presenters?
Can you hear me?
Yes, please.
Yeah. Thank you very much again for the interesting presentations. And one of the questions I have is relating to the hospital command center, which I guess it will trigger lots of interest. And I would like to ask what were the challenges to engage with the different stakeholders, which is a theme that it's keep coming up when you have to do this kind of large-scale implementations. Thank you.
Yeah, that's our challenge. I think the people who used to, have experience working in the hospitals, that's the challenge. So our experience that's why we like to start with the real problems of the caregivers. Then it's much easier to get acceptance. So when you start our project, we ask them what's the real problems you feel. Then second thing what we do, sometimes the people feels that that's a problem, but data didn't tell. Data show us different problems. So we interview them, what's the problem, then we analyze the data, then we discuss together, okay, this is problem you mentioned, this is data, can you have a discussion? Then we find the real problems, then we try to, then the next one is we try to find a solution together. So I didn't mention about some technology behind, but really depends on problem. We sometimes use digital twins, but we sometimes use the machine learnings or just statistical algorithms or just simple AIs to solve the issues, or sometimes we just show them real-time situations. Then it works. And when I heard from real workers in the command center and also the nurse in the ward, the first time they didn't like it. I mean, the nurse, or doctors, they didn't like it. Of course, people doesn't like some big brother is watching us every day. But it helped them in the workflow, and it helped them to focus on their own works because they don't need to worry about for example, like if you're the main nurse to prepare the operations, before our solutions, she has to check every test, each patient, they did that whole test, or even they ask, like next patients, they checked all the EMRs. Okay, this test wasn't done. When we can get the result? Do we have to delay the patients? But nowadays, it's not. We alert them, okay, this patient will have problems. Then can you check? Then you can also tell them, okay, this patient has a problem. Is there other patient can slot in from waiting list? So it really helped them to work in their real work. So we have a really good acceptance nowadays. Yeah.
Thank you very much.
Okay, next, I'd like to ask CEO Keith Airy, please.
So thank you, Professor Kim, and thank you for chairing this session. It's really interesting to have heard the various views from the panel members. My question is about something that I know very little about, but I did hear, and that is that in Korea, I heard that the medical profession was actually pushing back against the delivery of telehealth services, and that it is a kind of impediment to the general rollout of those things. So I guess, Mr. Lee, perhaps you could comment around your experiences with Health Connect in this area. Is this correct, or have I just misunderstood a kind of report?
Well, that's partially true if you see it from outside. Having been in this business for 7 years in terms of healthcare and working with a lot of doctors, there are concerns in terms of what telehealth market will do to their offline business. I think you can tackle it in two ways. There's institutional and there's also legal issues that need to be lessened in order to encourage and make telehealth business grow. We always feel that the regulatory issues are meant to keep the end users safe, and we have to respect that. And therefore, our portfolio CEOs, they're very well versed in terms of the services and product they sell, and therefore they need to persuade the doctors to really be able to rely on the quality of services that we sell to them. And once we get their credibility, then the next thing that we need to show to these doctors is that there's an incentive that will be benefiting them as well. So end of the day, we will work with the regulators, we will work with the doctors, and also the end users based on the value-added service that we can bring in terms of telehealth and other non-contacting health services that we will introduce to the market. Yep.
Okay?
Thank you.
Okay. Next, I'd like to ask CEO Singin Lee the questions among the presenters. Any questions?
I guess the question is that I have is regarding Command Center. Is one service that there could be some collaboration between small businesses that we run and work with that with multinational companies. I'd like to see if there's any collaboration opportunities.
Well, definitely, the G, we are very open companies. I mean, one of the example we did, I'm not sure, I think the Korean people who knows about the digital healthcare, I mean, I think you heard about Lunit. So we signed a contract with Lunit to sell their solutions outside of Korea. So we are very open to it, and also as people in Korea for GE Healthcare Korea. Well, I really like to promote our small company to overseas. So yes, we are really open.
Lastly, I'd like to ask Mr. Gwang Chang any questions between
Yes.
the presenters.
Actually, I have one question to Keith. I mean, Keith, during your presentation, you mentioned about the problem or issue with the connectivity of the different systems. So my question is it more related to human or technologies or regulations, or all of them?
I think it's related to all of them. And I think part of it is legacy problems, particularly certainly in some of the hospitals in the UK, there is very old IT equipment. At that very basic level, there is interoperability issues. As we move more into the into more modern times, these things are not talking to the older equipment and so on. So I think there's several different parts of that, yes.
But can I have one more question? If it's related to humans, is there any, because we also had that problem, and I think technologies, I think we can overcome, but the human being problem is also different. So is there any idea to solve that, or any experience?
I think this comes back to a point you made during your talk, Mr. Zhang, and that is that it is necessary to show to the users the benefits of using the systems, and that immediately gets sort of buy-in from the users, particularly nursing staff, as you I think rightly pointed out. And we have had this experience almost from the beginning of this company, which is now 10 years old, to engage very early with nursing staff in the development of the products, because they are the actual end users as far as we are concerned. And yes, it's necessary always to engage with the users around the benefits to them. So definitely, yes.
Okay. Professor In-Young Choi, do you have any questions among presenters?
I have a question to Keith. You mentioned that the role of the secondary hospital. So why you just focus on you think that secondary hospital should be more virtually rather than the tertiary or the primary sector hospitals?
I think that is simply a matter of the practicality and for the maintenance of care of patients who end up in, say, an intensive care ward. There's a lot of equipment which yes, it could be distributed. There could be tertiary care clinics, undoubtedly. And indeed, we are also involved in a number of programs of which are variously named things, but called EICU. And this is the use of technology to be able to connect a remote, highly trained physician to a regional hospital to be able to effectively deliver what is tertiary services to a patient. So yes, you're right. I think that the tertiary care can be distributed and will be, but I think that might take just a little bit longer. But to your point, one of the things that is very much a trend now is that hospitals are not being built in quite the same way. A lot of new hospitals are being planned as tertiary care centres more or less only, and the number of beds, hospitals are going from having hundreds of beds down to less than 100 for that very reason.
Okay. Finally, we will deal with the questions received in real time. As privacy became a social issue, I think that privacy issues will be much more sensitive than when handling with medical informations. I'm curious how personal data are secured in the digital healthcare solutions from Harold Choi. He's asking for the privacy problem in the medical informations. Who could answer on this? Please.
Oh, well, well, that's a very good questions. Privacy is very important. But when you see our regulations about privacy law and privacy information law, and also medical information regulations, it's really strict. It's really strict than your imagination. So what we are doing, I mean, when G maybe I can explain our experience. When G approached the new market with a command center or some other solution with IT, we check regulation in the country. And then we will meet that regulations. If we don't meet the regulations, we don't open the business in the country. So I think because of that, our system support cloud, but if the country or state doesn't allow cloud, then we can use the edge solutions in the premise. Then we are very safely monitored 24/7 for any hacking. So that's what we can say, and then we follow the regulations.
Okay. How about in UK? Keith, could you answer this? The privacy protection in medical informations?
This is a really interesting question, and I think as Mr. Jong says, the regulations are different in different territories. In the UK, the position is very clear. There are quite strict privacy laws, and manufacturers and users are meant to adhere to these. But very interestingly, we have seen over the last few months since the COVID pandemic hit, a change of attitude in many ways towards some of these rules. And I think again, it comes back to citizens in this case recognizing that the benefits of sharing some of this data outweigh the risks. Most of the data, I have to say, in the UK, in this case, is being shared with the NHS providers, and the NHS is very trusted generally in this way. I think that's not always the case with in some territories. The NHS will not try to sell us any products on the basis of the information we've given them, but I think, and we know that certainly a number of newer so-called digital health companies actually do sell the data that they have on their customers. And I think that's where the problems arise. But in the UK, generally, I think the data privacy is respected, but the paranoia about sharing data is passing.
Thank you. How about in Living Lab? Theo, could you?
Yes, thank you. Yeah, I was going to add that indeed working with citizens in almost everyday practice, it is very common to see that the privacy issue is a big concern and actually acts as an obstacle for any projects that we want to take forward. And I guess this is mainly to the lack of knowledge and awareness. And I think that we have the duty to educate our public about privacy and security issues. And I feel that if the public realizes, as Keith was saying, what are the benefits and how they outweigh maybe the challenges, they would be more than happy to share these anonymized data, in a, maybe you have heard the terminology in the past, in this data democracy approach, where people are sharing in a democratized way their data for the public benefit. But it is a big issue. I mean, in UK, which is a pan-European regulation, we adhere to the new regulations, the GDPR, which they are very, very strict. And one of the main elements is to make sure that the end user and the citizens are really aware of what the management of their data will be.
Thank you. And finally, we will deal with the questions received online in advance. Among these, there was a question that stood out. Hello, it is Viva Innovation, a digital healthcare company participating in the Korean National Strategic Smart City Program in Siheung City. In a situation where the local medical delivery system is not established, providing healthcare services centered on public health centers rather than local medical institutions causes great confusion in the medical ecosystem. And there are many concerns about whether it can be a sustainable model. I wonder if there are any overseas successful case studies where the government, private companies, and local medical institutions have partnered together to provide healthcare services to the citizens and have met their satisfaction. Grateful if you could share the successful case studies that you are aware of. Theo, could you answer this question?
Yes, thank you very much, Professor. Indeed, I mean, I guess the question refers to beyond our living lab, which is, I would say, relatively new. If you want to talk about open innovation ecosystems, you need time in order to mature this project. So answering the question about other case studies, I can definitely think of a case study from Denmark, which is the city of Svendborg, which is somewhere in the south-central Denmark, in a small island, where it is the e-health city, which is a very good example and a more mature living lab, where they're actually working in neighborhood streets. And the main element is exactly what the question is asking, where the local government with companies and the healthcare system, which includes a university hospital in the area, they're working together to accelerate this innovation and find solutions, predominantly new care pathways. And the preliminary data, they show that it actually works well. Reflecting on other cases, it is not very common to see the approach that either ourselves or in Denmark, the Living Lab takes, which is working in real environments outside in the neighborhoods. Usually the Living Labs are using what I would say artificial environments where everybody needs to travel and go to this area. But just reflecting to another more recent, I would say, example, there is another Living Lab in UK in the Westcote village, which actually focuses on exploring solutions between ambulances, paramedics, and the local government, how they can improve the services that the ambulances are offering in this area. So the two examples and case studies I can think of as a more mature examples of Living Labs beyond ours are these two. Thank you.
Okay, thank you. The second question is following. Digital healthcare seems to be progressing with an emphasis on the digitalization of hospitals. Ultimately, it is expected that remote medical treatment is required in the smart cities, but I am curious about the progress of current technical level and policy progress for telemedicine in the UK. Could you please explain and what should be the top priority in order to adopt telemedicine? Please answer, Keith.
So I think that there's several parts to this to answer this well. I think just for information, there is a relatively new organization that's been set up by the National Health Service called NHSX. NHSX has a very clear set of objectives, and they're just three things. First, digitize. Second, connect. Third, transform. And they are now working very focusedly on the transformation side of this, where remote patient monitoring in particular is a key aspect of that. So this is not something which is yet widespread, but what we have seen, and I think this is extremely interesting, is that because of the COVID epidemic, GP consultations, GP surgeries in the UK were places, there are many of them around where people would go, and because of COVID, a lot of those visits to the GP, most of them, could not take place. So from earlier this year, around 3% of GP surgeries had the ability to perform online consultations. Today, it's 99%. An extraordinarily fast change because they had to do that. And many of these consultations now are done through relatively simple standard platforms. Even Zoom is allowed for this kind of thing. So I think we are seeing a rapid change, and associated with this has been work around COVID itself, where the remote patient monitoring is being done in relatively simple ways, and one of the most powerful indicators that was used as a predictor was pulse oximetry, oxygen saturation of the patients at home. And that made having just that parameter plus the patient-reported measures made a very big difference. And that was work that was done in 3 centres just around where I live in Oxford. And we know that there were many other pieces of work like that which were carried out earlier in the pandemic. So I think because of that, because of the learning at that stage, principally around the remote delivery of care or telemedicine in one form or another, it's very likely, and I hope I'm not talking out of turn, but I think it's very likely that the number of deaths in this second wave of the pandemic will be fewer than in the first wave, or relatively fewer.
Okay, thank you very much. And we have third questions. Compared to foreign countries, Korea has many legal and institutional restrictions related to digital healthcare. How can it be commercialized? Please, CEO Seung Lee.
Oh, this is a question that was similar to before, but just repeat to my earlier response. I think it is really up to the healthcare service provider like us to really tackle the issue of getting the credibility of the stakeholders here, who are the doctors as well as the patients. This is a new concept that hasn't really been rolled out in Korea, and therefore we specifically ask our portfolio CEOs to really and educate the buyers, in this case doctors, and then also the patients. And once we prove that in the market, and then there are legal issues to tackle. As we all know, that the regulations are there to protect ultimately the patients. So once we get the buy-ins from the market, the players who are treating those patients, and the patients who appreciate the services, and then we will benchmark what other markets have done, and therefore we will go with the regulators and persuade them that these are actually proven products and services, and therefore that should be relaxed. But so it's more of a market-driven sort of approach of tackling the restrictions, and therefore hopefully that Korea will get there near time soon. And I think the likelihood is stronger because of the COVID-19, and that has really accelerated everyone in the market outside of Korea, and then Korea is also catching up. Thank you.
Okay. Thank you. The first question is, I wonder how the role of medical staff will change when the ideal future smart hospital is realized. Please, Kwang Hee-jang, could you answer this?
Yep. I'm not sure smart hospital will change the role of the medical staff and caregivers. I think as a potential patients in the future, I like them to focus on me. I think that's their own job, right? So the caregivers or medical staff, when we can provide a lot of new technologies, I think we can help them to focus on their own job. Their own job means to take care of patients. Mm-hmm. So nowadays, if you see, really, I mean, they're doing a lot of other jobs than their own role. So I think that will help them to really focus on their own job. And second thing, what I think is, in order to, because we have a shortage of medical staff, it's difficult to have the right medical staff, medical staff with the right quality or good qualities. I think all the digital technologies can help our medical staff to have shorten their learning curve. So I think it will really help whole the societies. Thank you.
Yeah. Thank you for your answer. And this will be the last question. From the perspective of smart healthcare resilience, I think treatment should be easy and access to treatment should be high. I'm curious as to what direction smart healthcare should go in to implement this. Professor In-Young Choi, could you answer this?
I think this question is still challenging for me as well because I'm working at the Catholic Medical Center and also I'm working at the Seoul St. Mary Hospital. So the Catholic Medical Center has tertiary hospitals as well as secondary hospitals. So I think that we have to think about how to move this hospital into the smart hospital. 2 years ago, we announced the digital transformation. So I'm thinking about that a lot. Today, I learned 3 things. The first one is we need to focus on 3 things. First one is connectivity, and secondly, data integration, and third one is the people engagement. So thank you for the first speakers. You give us a big lessons. Thank you.
Thank you. And we have another, this will be the last real-time question from the audiences. Can you introduce us more citizen engagement cases in living labs in UK? Can you elaborate how patients can participate in living labs? Theo, could you answer this?
Yes, thank you. Very good question, because the living lab experience that I shared predominantly refers to what I call, and I not by chance I use the terminology citizens, because we are focusing on people that they haven't escalated their care needs yet, because exactly what we want to achieve is keep them healthier for longer. In terms of engaging with patients, just reflecting to recent projects that we are conducting due to COVID-19. We are participating in projects that patients are having treatment in their community, patients that they have been discharged from COVID hospitalization, and there we engage with patients themselves. I am aware also of examples of living labs that they are being based in hospitals. But the big challenge there is that when you want to collect data from end users, if you're focusing on patients that they are hospitalized, the term that someone will be in the hospital is limited. It can be prolonged, but still the time frame is limited. At some point, these patients will be discharged. So the data that you are planning to collect, there might be broken at some point because the patient left. So that's why, again, I'm saying that our focus, even working and engaging with patients, is looking in the community, so where patient stays longer. Thank you.
Okay, thank you. The time is almost over. Lastly, we will listen to each speaker and panel for about 1 minute each. From UK first, about Keith? The last 1 minute.
Okay. Thank you, Professor Kim. I think really I would just like to just sum this up by saying that thank you very much to start with, and also that what we're hearing today, I think from all of us speaking, is that this is a journey that we're on. I think it's a very interesting journey. It's one which is part of a long history in healthcare, which is now some, maybe 150 years old in the form that it's being practiced today. And in the last few months, we've seen changes which wouldn't have come about without this sort of big disruptive step. And I think the
this journey that we are now on is going to be an extremely interesting one, will have benefits for many, many people. But there are a number of issues, one of which is the whole data privacy issue. But yes, and it's very nice to have had the opportunity to speak with some fellow travelers on the journey. So thank you for that.
Thank you. And the next is Theo.
Yes, thank you. As my predecessor just mentioned, a big thank you for the invitation and the chance to participate in the panel discussion and for a fruitful discussion. And I think that the key to accelerate the adaptation of innovation is to have responsible innovation and genuine stakeholder participation. I mean, reflecting to all the projects that we've heard about today, it is very, very important that industrial partners, healthcare professionals, government, local government and commissioners should sit down around the same table, having the patient and citizen in the core of what they want to do, and take these visions and dreams forward. Thank you.
Thank you very much. And about In-young Choi?
Yeah, I think now the technology is not the problem anymore. I think we need need to have a more clear vision and directions for the medical staffs and also patients. And so, as Theo said, we need to know how to collect the opinion from different stakeholders, I think.
Okay, thank you. And about
Personally, I learned a lot today. You know, it's like the ideas from UK is something new for me, and also idea from Seung Lee and so then discussions. I think it can have many lessons. And now I think, as a fourth mentioned, I think you know, we have a common visions, or so we need to think how we can collaborate together to move forward. So I think that's something we really need to think. Thank you.
Thank you, Vice President Kwang Hee-jang. And let's 1 minute talk from Seung Lee.
Well, as I started this presentation, I hope this symposium will be the right stepping stone for further collaboration. And ULake, we always believe in ecosystem, and therefore we would like to invite and work with the best in terms of new technology to be shared. And ultimately, our goal is to personalize healthcare and also innovate to better serve our customers. Thank you.
Thank you. This concludes the digital healthcare session. Thank you to all the listeners who watched until the end, and to all those who directly participated by sending questions. And please stay tuned to the upcoming session on smart mobility at 7 o'clock in the evening. Thank you very much.
Thank you.
Thank you.
Thank you very much for all speakers. We are now closing the digital healthcare session for the symposium. From 7 p.m. Korea time and 11 a.m. UK time, smart mobility session will be started. And we will appreciate all of your interests and participation. Thank you.